Welcome, everyone. My name is Haley Buckner, and I'm the Professional Relations Manager for Elevate Oral Care. Thank you for joining us this evening. Before we start, I'd like to cover a few housekeeping items. For those of you who remain online past 50 minutes, your CE certificate will be emailed within hours of the completion of this talk. Be sure to check your spam folder. You are all muted, so there's no need to worry about background noise. We will have time at the end for questions, and you can submit questions on your webinar dashboard. They will be tracked throughout the talk. We have hosted an extensive series of free live CE webinars on many prevention topics. Each of these webinars have been recorded and are available with free self-instruction CE at elevateoralcare.com/elevatingcare. Bookmark this page and return often to see what's new in free CE. If you have a topic you would like to see covered, feel free to suggest it by sending an email to info@elevateoralcare.com or by completing the webinar survey that will be sent after the completion of the talk this evening. We enjoy looking through your suggestions and creating webinars based upon your requests. Tonight, we are honored to be joined by Dr. Amal Nureldin as she touches on our most highly requested webinar topic of Silver Diamine Fluoride with Beyond Decay, Unlocking the Power of Silver Diamine Fluoride for Oral Health. Dr. Nureldin is clinical professor, director of preclinical program, and the director of the prevention program and department head of dental public health services. Dr. Nureldin specializes in 3 areas of dentistry: operative dentistry, preventive dentistry, and cariology. She received her dental degree in 1993 at Faculty of Oral and Dental Medicine in Cairo University in Egypt. Nureldin began her career as a dentist and a faculty and earned Master of Science degree in operative dentistry at Cairo University in Egypt in 1998. She earned her Master of Science in Biomaterials in 2003 from Baylor College of Dentistry, Texas A&M, and her PhD degree in operative dentistry in 2007, with joint supervision between Baylor College of Dentistry and Faculty of Oral and Dental Medicine, Cairo University. Dr. Nureldin is a dentist, scholar, educator, and a dedicated mentor. Her research has focused broadly on the prevention and treatment of dental caries and white spot lesions. She serves as the principal investigator in multiple research grants and projects supported by industry, contracts, and intramural grants. Dr. Nureldin has made significant contributions to the field, publishing in peer-reviewed journals and contributing a book chapter to the first published work on Silver Smart Oral Health, the medical management of caries. Furthermore, she has taken a lead role in clinical research, specifically in testing novel clinical applications of silver diamine fluoride. In recognition of her exceptional leadership qualities and achievements, Nureldin was honored with the Distinguished Teaching Excellence Award in 2016 and the Clinical Faculty Research Award in 2019 by Texas A&M College of Dentistry. Dr. Nureldin, thank you so much for joining this evening, and I'm going to turn it over to you.
Thank you very much, Haley, for this nice introduction. And as Haley mentioned, I have been in dentistry and practicing dentistry for over than 30 years. And my career shifted actually from delivering drill and fill dentistry for over than 15 years to prevention, to total prevention, and cariology teaching. In this presentation today, Beyond Decay, Unlocking the Power of Silver Diamine Fluoride for Oral Health, I would like to have certain disclosures. I declare that neither I nor any member of my family have a financial interest in any commercial products discussed in this presentation. And Elevate Care is the financial sponsor for this presentation, but none of these products are being endorsed by me. Another disclaimer is my quest for knowledge is eternal, and I am committed to the unending journey of learning. So our objective today in this webinar is to understand the science behind silver diamine fluoride and also some clinical aspect in using silver diamine fluoride explore the potential of SDF beyond treating decay. So I would say in a nutshell, it is explore the what, the why, the when, and how of SDF. I know that many pioneers in the field have lectured on SDF, but I feel it is an ethical obligation after knowing the power of SDF and what it brings to the dentistry field to remind and to revisit all the possible opportunities and all the wide horizon that SDF can bring. When I look at the SDF, I would see a real person-centered care and a huge care about the holistic health of any individual and all the patients. So again, it is unethical not to apply it and not to use it whenever possible to provide this holistic approach. And I will start with a very close story to my heart, which is my 40-year-old Down syndrome brother who happened to have lost some restorations and some decay, as you can see in his anterior 8 and 9, as well as number 3, number 4, and number 14. He used to live with my 80-year-old mother in Egypt. And when I visited before the pandemic and I saw his teeth in this condition, I had SDF to give it to one of my pediatric dentist colleagues to use it in his clinic. So I applied this to my brother's teeth. And then I had to leave. 8 months later, I reapplied again, and I want you to see how the tooth looked like without any restoration, no pain, no complaints. Afterwards, glass ionomer has been applied to his teeth and also to his back teeth, as you can see right here. And this has been going on for 18 months with SDF. No pain, no fear, no emotional stress. And this is the ultimate success I can see with an adult special need applying SDF in this way. So Silver Diamine Fluoride, let's revisit. We know that Japan has been using SDF since 1870 as a dental therapeutic agent. And back then, black teeth was considered to be beautiful. Not the case with us right now in modern dentistry, but this is what they were thinking. So let's start with the what is SDF. So in 2014, SDF has been cleared by FDA for treatment of hypersensitivity. And then in 2 years, it got a designated breakthrough by FDA to be used to arrest decay. And in 2021, it was given the medicament application as a caries preventative agent, but also the WHO included SDF in the WHO model list for essential medicine, and actually it's considered the SDF a medicine which everyone should always have access to, and that all government should be using it to their population, and it should make it available and affordable. But is it available? Unfortunately, not everywhere and not in all countries, but this is our mission to talk about it and to showcase what can SDF bring to the patient-centered care. So what is really SDF? Silver Diamine Fluoride is a colorless, and it could be tinted blue, of course, and that's the best thing that the companies did to tinted blue. The alkaline solution is in a range of 9 to 10. Not all the products had this alkalinity, but we're fortunate that the first product in the United States by Elevate Care, which was Advantage Arrest, was pH over 10. It has silver, ammonia, fluoride, and water. And the fluoride is 44,000 particles per million. It is double the amount that is found in fluoride varnish, which is very important, and we will discuss why. Once we apply SDF, this is what any dentist can see. They can see black stain. They can feel a hard, arrested decay in many, many lesions, and some prevention. Some sound areas do not develop decay, and also they noticed a healthier gingiva. So when we talk about why, it's very important, and as an academician and a researcher, I always tell our students and talk to them as well as talk to the dentist that it's very important to understand the strength and limitation of any dental material that you're using. That's actually the power that will lead you to use this material to its ultimate potential. So when we said that SDF has silver, ammonia, and fluoride, in a nutshell, silver is bactericidal. Ammonia, it's a solvent providing stability to this compound. And fluoride, it's very important for remineralization, which is a well-known fact to all dentists. So when you find all the abilities of each one of those and what it can bring, you can say it can arrest caries, it can prevent caries, and actually it can decrease the hypersensitivity. So what's on the label? Actually, treatment of hypersensitivity for adults above 21-year-old. That's all what we have on the label as a device cleared by the FDA. The good news that there will be some good news going to happen by the end of this year, and I will mention it later on in the presentation. So of the label, it's going to be arrest of the dental caries, prevention of dental caries, and all other applications beyond the treatment of hypersensitivity. Now, there is something very interesting about SDF, which is an immunization concept. There is evidence that is being very strong about using the word immunization. And there was this very interesting paper published in 2018 by Dr. Shro showing that the arrest of decay and prevention of infection can be actually compared to vaccination. So SDF can halt caries, vaccination can stop the infection. And SDF can slowly release the silver that reduces the reinfection, as well as the vaccination. It will reduce or prevent the reinfection. Also, SDF, fluoride will strengthen the enamel, and the vaccine will strengthen the immunity of the individual. So this was a very interesting concept. Now, let's come to one of the first whys, being bactericidal, giving a halo effect. What does that mean? There is a noticed inhibition of the biofilm and noticed inhibition of formation of dental plaque. There is also a bactericidal effect on the bacteria, so it dies. What happened afterwards? There is what is known by halo effect. Silver keeps leaching out, affecting all the mouth. This is what's called the halo effect. And then there is a zombie effect, which I loved it when I learned about this. The silver killed bacteria. When it comes near the living bacteria, it leaches the silver and it leads to killing the living bacteria. This sustained release of silver leading to a sustained bactericidal effect that lasts in the oral cavity. How about the remineralization and caries resistant effect? We have silver and fluoride that really helps in the remineralization and this ability to resist caries. So silver and fluoride penetrate deep, and we know that fluoride is our icon for the remineralization. So in the sound enamel, it can penetrate up to 25 microns, in the sound dentin into 200 microns, and the presence of fluoride will lead to the formation of fluoroapatite or the calcium fluoride, which is the reservoir that the any lesion needs it to avoid the demineralization or to enhance remineralization. This is very important with the presence of alkalinity that will also lead to neutralization of the acidity within the environment. What else? It is a profound desensitizer, as we mentioned, and that is really what's on the label. Why it is a profound desensitizer. And this time it is because of the fluoride, which is 44,000 particles per million, as well as the presence of silver. Both of them can occlude the open dentinal tubules, blocking the dentinal tubules, and there has been many case studies that has been published that actually talks about the immediate suppression and desensitization that has been offered applying the SDF. Now, that's a great product and many advantages. Definitely, we need to look also at the limitations so that we can have a full power of how to apply it, when to apply it, what to do with those limitations. Black staining, it's not a secret to hide, and but the good news that this black stain is only happens to the decayed dental tissues. And to me, I see it's actually a good thing because it is a storyteller. It will tell the patient that you have decay at this area, you have decay at this tooth, you have decay at this surface, so it can detect the caries. The silver ion will bound to the denatured collagen only, but not the intact structure, so it will demineralize. Unfortunately, this black stain is not only to the decayed tooth structure, but it can stain the soft tissues, a temporary tattooing of the gum, of the lip, and we will see in the clinical application how we need to be very careful and train our staff in how to apply it, how to protect all the soft tissues. And also, it can stain the table, it can stain our gowns and our hands. So we have to be very careful about this. The staining of restoration and crowns, I will say not likely, but we will discuss a little bit more once we reach the clinical aspect of SDF. The acceptance of this dark staining was a subject of research, and there are multiple research that focus on the acceptance of SDF staining by parents, by patients, And I would say, to summarize, because I put two examples here, but this dark stain to a great extent is in our heads as dentists and as dental health professional, because we love the great aesthetic. But for patients, there are other priorities that they look at, that really this dark stain is not the big issue. The first patient I used SDF on was a leukemia patient who was 28-year-old, and they had to pull out all of his upper teeth before starting the chemotherapy and radiotherapy. And when he came to our AGD clinic, his lower teeth started to decay, and they couldn't touch him to avoid the osteoradionecrosis. And I was conducting my clinical research, so I had the SDF available, Advantage Arrest by Elevate Company, and I applied it to his lower teeth. He didn't mind at all this dark stain. He was extremely happy that everything got arrested, and we put we put glass ionomer, I'm sorry, on top of it, and we moved on, and things were great afterwards for him. So this acceptance or rejection, it happens that there will be no acceptance for this dark stain, but we can go around it, or we can explain it more to patients. Another thing is the metallic taste. It gives I would say, a little bit yucky metallic taste for adults, for children. But if we apply it and then cover it with fluoride varnish, it masks this metallic taste to a great extent. Also, if it touches the gingiva and the mucosa and the lip, there might be a little bit of irritation, but it's actually very transient, and it goes away very fast. A fear of the toxicity, I would say this is insignificant chance of toxicity, and there has been studies about the toxicity and many talks, and I'm not going to mention the safety portion here, so, because for the time limitation, but I would say insignificant and unreported toxicity from SDF if we follow the instructions. And also the last limitation, yes, it is a biological tool that is very powerful to arrest decay, but it will never restore the form and function of this tooth. And this is very important, that we restore the form so that this tooth can function properly. With part 3, we're going to discuss when to apply SDF. We always have to remember, it's not a treatment for all. And I will address this in after a couple of slides, but I would say we can apply it to children, to adults, to elderly population. So especially the patients who have no access to dental care, rural areas, special needs, elderly patients with root caries, patients undergoing radiotherapy for head and neck cancer, and also when we need a less invasive treatment. This is very crucial. My second case was a 78-year-old female who came to the AGD clinic with crowns and with exposed roots. She never wanted those crowns to be removed, and she was very adamant not to remove them, but there was decay in the cervical region of those teeth. So we applied SDF 3 consecutive weeks, and we followed up after 6 months. Everything was perfect, and we never needed to remove those crowns, and we followed after 18 months, everything still perfect. So it can be indicated for treatment of dentin hypersensitivity, and there has been several published cases about this and how it can provide an immediate, profound desensitization of the hypersensitivity. And we can manage actually the dental caries control when we have a patient with extreme xerostomia, inaccessible lesion, and I need to control the fire. And I'm using this analogy of Dr. Frischella because it is really powerful, where we have such oral cavity that has multiple and rampant decay everywhere. You need to control the fire before you call in the engineers and the designers to treatment plan for this oral cavity. Also, if there is a furcation involvement, and when we have a non-symptomatic active caries that is happening. Also, if I have an occlusal surface with an incipient lesions, deep pits and fissures within enamel, exposed roots, all of these we can apply SDF. Also, we can use it in partial caries removal, stepwise, indirect pulp capping, and deep caries, or disinfecting root canal and endodontic therapy, where the SDF can be diluted. A very interesting idea for research that can come along to see how we can use this in dental treatment and in root canal therapy. Now, contraindication. Without a confirmed informed consent, we actually need to stop and not apply it. I would recommend always have an informed consent from the adults or the guardian of a child. Also, if the patient has allergy to silver, fluoride, or ammonia, sores, ANUG, ulcerative gingivitis, of course, if we have a pulp exposure, we should not apply SDF. These are the contraindications. We need to remember one thing: it's not a cure for all, and it's not a treatment for all. It's a great tool, but we have to remember as clinicians and many other dentists who lectured on this topic would say that the clinician needs to be prepared for the dark stain, how to tackle this, and also for stains that can happen to the soft tissues, stains that can happen to the clothing, and also that some of those cavities might fail with a percentage of 11 to 32, and it will never restore our form and function or aesthetic. So we need to do the second step as dentists and fulfill what is needed to restore. The area that I love about the SDF is that it is really beyond decay, and how to think beyond decay. It is very powerful, very successful in arresting decay. But 6 years ago, the idea of SDF capable of improving gingivitis hit me so hard that I wrote a clinical research grant and applied, got awarded to work on this, and finally it got published 1 month ago. It is about the efficacy of 38% silver diamine fluoride in reducing gingival inflammation and plaque accumulation in older adults living in retirement home It was a randomized controlled pilot trial. We went to retirement homes. We recruited elderly who has gingivitis and allocated them to two groups. One received silver diamine fluoride and the other arm were placebo, who received a saline. We applied SDF 3 consecutive weeks, and we captured at the baseline as well as on week 5 and week 7. We actually captured what we needed, which is the periodontal index, gingival index, and we got some photographs of those patients, and we analyzed the data. It was very impressive results. And I would say, look at those images. This is before. We did not instruct the patients to brush or not to brush. We left them with their own oral hygiene routine, and across the board, all the patients whom we see, they were not brushing, and we captured this also. So as you can see, the amount of dental plaque and the amount of the gingivitis that they have, and I would say periodontitis as well. And after 3 weeks, this is what we saw. Of course, the areas that were decayed after applying SDF to only the tooth surface were stained dark, and improvement in gingivitis to a great extent, and less amount of dental plaque formation, which was a huge thing to see. That's the case before and after 5 weeks. Huge improvement. Another patient where you can see before and after. And this is also one patient showing how gingival improvement before and after 3 weeks. And of course, the staining can tell you that these are the SDF group. Now, the other idea was about also beyond decay, SDF and prevention. So I was thinking of those adults who develop decay rapidly because of adversity that they are passing through. And my thinking came to the head and neck cancer patients who are about to receive radiotherapy, and it will affect their saliva secretion. And we know, it's in the literature, they can develop radiation caries in 6 to 12 months, very rapid, because of the severe xerostomia. And the patient is in I would say mental state and psychological condition that does not put them in this arena of I'm thinking about my teeth. They are in a pain, they are in agony that they actually do not focus with their teeth. And as you can see from those images, that's the deterioration that can happen to patient who received head and neck radiotherapy. So my clinical research that is ongoing right now, and I'm using silver diamine fluoride 38%, we are applying SDF before radiotherapy and 1 month post radiotherapy, 3 months post radiotherapy, and capturing gingival index, periodontal index, and ICDAS, which is the caries development within this oral cavity. This is what we capture at baseline after treatment. We have two groups, one group who are receiving the SDF and the other group receiving placebo. Of course, we are giving them the baseline and the gold standard in prevention of radiation caries, which is a prescription toothpaste for both groups. I'm hoping to see results. We are about to finish this clinical trial. Very promising results so far. Reaching part 4, it's about the how. How do we apply SDF? And again, it's a refresher for what we know and more addition to some clinical tips in there. Very important to have a informed consent. Don't forget and don't get into the habit of just applying it. We have the consent forms online available for all of us in 7 languages, so it's very accessible and you can use it. I adapted the form from the UCSF, and it is actually in our school. We are using it, and we are giving all the options to the patient to make them aware of the non-restorative and the restorative treatment options, and the what can SDF provide and the limitations of SDF. The setup of the tray is very basic. You don't need complicated stuff. As you can see, the Depton dish and the, or if you're using the small vial, and we will see this, cotton rolls, I would say we're missing here the Vaseline or the cocoa butter that you need to apply to the gum as well as the lip to avoid staining. Fluoride varnish is a good practice as well, that can be applied. We know that there will be staining, so we shouldn't be playing with it. These are products that is available in the United States. The most recent is Silver Sense SDF by Centrix, and Revistar Aqua. The one that is first introduced in the United States was Advantage Arrest by Elevate Care, and recently they introduced the gel, which I love because it is confined to an area and you can see where it is exactly. Now, a new product that is going to be in the market in mid of 2024 is the Black Diamond Silver Fluoride 40% and Stainless Fluoride 10%. This is not a new player in the game. It has been used in Australia for over than 20 years by Dr. Craig, and it is called Dr. Graham Craig formula. Actually, it got the FDA clearance just in June 2023. And again, it's on the label, it's for treatment of the dental hypersensitivity. It has 2 steps. One step will apply the silver fluoride at 40%. The pH is very low, 5.5, no ammonia, no smell. And the second step is the stainless fluoride at 10%. It is unlike the use of potassium iodine. Black Diamond will deposit silver, not remove silver like the potassium iodine. The feedback about this, it makes an immediate darkening and hardening of the lesion. Also, something noticed by clinicians, it improves the gingival condition. It can be, so imagine the broader usage of those products in nursing homes, assisted living, special needs. It's huge. It's really a big thing. How do we really place it? I would say you need to select the case. You need to really decide about the frequency protocol, and then you need to monitor the response of those lesions when you applied SDF. So you could go from no restoration at all to the same day restoration, or you apply it and wait for a while, which is called multiple days restoration. We let's discuss the step-by-step SDF placement with no restoration. This is a very important paper that has this clinical tips that would be very beneficial if you go over it in Compodium in 2021 by Dr. Young et al. First thing that you need to do is apply the cocoa butter or the petroleum jelly or Vaseline over the lip and the gum. Try to protect as much as possible, but avoid smudging the teeth, because we want the surface to be available, readily available for the SDF. I would say you need to isolate with cotton as well and desiccate, air dry as much as you can. Apply with the micro brush, let it soak in for at least 1 minute. No rinsing is needed. Then apply the fluoride varnish. It's not a must, but it is optional. It will protect the SDF and it will mask the taste. You see in my screen that I said apply every 6 months, and this is, you will see it is ADA recommendation, but it is you're the dentist who's gonna decide what's going on with the lesion, how big it is, do I need to see the patient or not? And as you heard me saying in my clinical studies, I used it actually very frequent than what has been recommended by the ADA for arresting the decay. Proximal application, we should go ahead and also desiccate, use a super floss, apply to the end of the super floss, and then pull it out so that this interproximal surface will be coated with SDF, or we can apply it with a micro brush on the occlusal lingual buccal embrasure and with the capillary attraction. It will move and come in contact with the interproximal surface, and it was very successful in our clinics doing so. Recall of the patient and reapplication. Again, as I mentioned, ADA said biannual, and I would increase the frequency if I have a lesion like the one on top, if I left it open with no restoration. Bring the patient back, apply until you feel it's hard to the probing with an explorer. How frequent? The follow-up and post-application instructions, it's all based on your assessment, and there isn't any post-application limitation. The patient is permitted to eat and drink shortly after the application, and no changes is required to their oral hygiene practice. It's just this 1 minute soaking in that allows the SDF to diffuse as deep as possible. So that's the evidence-based clinical practice guideline released by ADA in JADA in 2018 that mentioned the SDF being used for the non-cavitated lesions. Now we have the SMART technique, which is a step-by-step SMART restoration, same day or multiple days. So now we applied SDF. We would like to restore it. We would like to restore the function and form. How do we do this? What is SMART? We know the art, but now we have silver modified atraumatic restorative treatment, our technique. How do we use that? As you can see, this is an SDF treated lesion on the left, and now on the right you see a restoration on top of it. But what is this restoration? It is actually glass ionomer, which is the best restoration that can be used on top of the SDF. It's a huge science. It's a huge talk about it, which is not our place right here. But I would say it's one of the best and preferred material for restoring on top of the SDF, because it has a water base and has a significant anti-caries effect, and less recurrent decay around the margins, long-term release of fluoride ions, and if we are using it with SDF, it will provide me with a better aesthetic to avoid the leaching of silver that might happen with resin composite. One thing, when you mention glass ionomer, you cannot neglect talking about is the chemical fusion zone that is formed between glass ionomer and the tooth structure, which is the chemical hybridized layer. This is very important. It provides a huge and a very strong bonding to the tooth structure. So same day smart, I will go through those pictures and case very quickly. Many presenters before me use those. It's very valuable because you can see some things that in the technique that can be avoided, like this dark marginal areas that shows inadequate caries removal around the parameter. I would say the caries has been arrested, but this is the discoloration that is happening. What we can do is remove 2 millimeters from the cavus surface margin when the enamel is present, and 1 millimeter if there is no enamel when we are talking about the root area. This is crucial. So I would show you this. Moshi dentin, we use a retraction cord to pull out the gingiva from the tooth because it is a little bit subgingival, a little bit desiccation. Soaking a retraction cord with SDF will lead to tattooing of the gum. This is what we don't need. You can apply the retraction cord and then remove it and then apply the SDF. Removal of the cavus surface margin, about 2 millimeters, will provide us with this clean margin that will not give us this dark stain underneath. Since you're going to use glass ionomer, you have to use the polyacrylic acid. Very important because it removes the smear layer. That's what you need to do. Rinse with water for 10 seconds. And maybe not reapply SDF. We use both. And there might be another dentist who has a different opinion. That's fine. And then mix the glass ionomer, apply it, shape it, and that's the end result. Okay, how about the multiple appointments smart, which I advocate for big time, that wait and so that you can check the successful application of the SDF and how the lesion is really hardened. We do have a glass ionomer smart technique, and we do have a resin composite if they want a more improved and a better aesthetic. Now, it is always better successful with more aesthetically, with more time of wait. So with resin composite, if you have multiple appointments, that would be great. If you have a same day, you should be very smart applying composite resin on the same day. So maybe wait the 1 minute or couple of minutes for the SDF to penetrate, and then light cure so that you can see where is the dark discoloration and remove from the cavus surface margin to apply the the composite resin and avoid the leaching of the silver into the composite while it is cross-linking and fully polymerized. Need to monitor the lesion, especially if it is opened and not restored. It will give you this tactile hardness of the dentin, and it will lead to eventually making you think you're successful or not in arresting the lesion. Insurance and coding, 1208, that's a fluoride. 9910, desensitizing medicament. 1354, it is for caries arrest. And of course, in 2021, 1355 was for prevention. And the insurance reimbursement for the 1354, not in all states, but there was a success in making insurance companies pushed towards reimbursement. Now, some clinical aspects real quick because of the time as a Q&A question. So, will 38% SDF stain composite or crowns? We would say surface layer staining is possible if the SDF passed beneath the area of contact into a restoration, and if there is a gap in the restoration, this eventually would happen. But if it is on the surface area, standard pumice can remove this discoloration. We didn't experience any discoloration in crowns when we applied that, but if we have a composite that really has a marginal leakage, it will help us actually diagnose that there is a demineralization around the compromised composite. And this was, as I mentioned, the crowns did not stain. This was the AGD patient who actually had the SDF applied to all the cervix of her teeth, exposed roots, and the crowns did not stain. How about stains? Stains for the lip and skin, surface, fabrics. For the lip and skin, it will actually go in a few weeks, and hydrogen peroxide or makeup removal and exfoliation of everything will go away. The surfaces use sodium hypochlorite and some of the very safe household cleaning products. Tried that. It happened with our dental unit, and we kept using the cleaning products until it is clear. The fabrics, we need to use certain products for the fabrics, but unfortunately, I don't think it is very successful. So we have to be extra careful. Informed consent to protect yourself and tell the patient about what's going on is the key to go around this idea of the stain and try to help if it is superficial and you can clean it. What does an arrested lesion treated with SDF look like on a radiograph? I would say the arrested lesion looked like a scar, and you cannot really tell if it is a decay or not, so you have to document. So if the patient moved to another dentist, they will find it in their records. I can say that based on my brother's x-ray, as you can see in the pano, but it looks like a scar. Documenting is very important, and to know if a lesion is arrested or not, the best thing is to use the tactile hardness of the dentin surface. How about using SDF as a cavity liner? I would say it is cleared in the same FDA category as a cavity liner, although there are no head-to-head clinical trials comparing the SDF as a cavity liner, but it has been successful being used this way, and it will not discolor the intact, safe, sound enamel and dentin. Can be used as indirect pulp capping with the 3120, yes, and it will arrest the residual decay left in there, and it can form a secondary dentin, initiate, and the pulp to deposit the secondary dentin. But it cannot be used as direct pulp capping. If you see the pulp exposure, it cannot be used. Should we light cure it? I would say not recommended. We would love to have the silver penetrate and stay there and allow it good time to penetrate. Light curing will cause the silver to oxidize before allowing it to fully penetrate into the tooth. If you're placing a restoration on top of it, treat the surface, and you want to treat the surface on the same time, just wait for a while until the SDF penetrates in depth, light cure the area that is going to receive the restorative restoration, and this will actually prevent or reduce the grayish discoloration because we are oxidizing the silver and getting rid of as much silver as we can. How about the SDF and usage on a prepared tooth just prior to restoration or cementation? So I would say it's a potent desensitizing agent, and it has been shown to be protective of the pulp when placed on crowns, preps to reduce the dentin hyperpermeability. I've known of one dental school that actually told their students to always use it as a routine on top of the preps before they apply the crowns. It is a strong desensitizer, so I would encourage doing this. Does an SDF treated site compromise the bond strength of a glass ionomer or resin composite restoration? And I would say no. And recent studies demonstrated that SDF treated lesion did not affect the bond strength. A final shout out to our medical management of caries that has been driven by Dr. Steve Duffin, fabulous 32 authors, has plenty and tons of information. Of course, we have more coming up and more research, but this book is where you start, and it is actually present free online. And I was very honored to be one of the co-authors in this book. Thank you very much for staying with me this 15 minutes, and I'm open for questions if we have any questions. Thank you.
All right, Dr. Neraldin, thank you so much for a wonderful presentation this evening. Your Q&A session there towards the end answered a lot of the questions that some of the attendees had been typing in, so that was perfect. But we did have just a couple more that I'm going to address here so we can make sure we try to answer everyone's questions. The first one is SDF safe for pregnant and nursing mothers?
That's a really good question. And I had a couple of patients asking about this. And you know, when it comes to pregnant mothers and expecting mothers, and you would be a little bit cautious about it, but it is safe. And when it's safe for children, safe for adults, and we are working within the safety measures and the amount that is needed and the period and the frequency that is needed, it is totally safe.
Okay, great. Thanks for addressing that. Another question came in, and we saw a couple questions about working with geriatric patients. And someone mentioned that they work with challenging geriatric patients, and they were wondering just how plaque-free those areas of application must be, as sometimes these geriatric patients have very little attention and cooperation. So they're wondering how clean that area needs to be before applying silver diamine fluoride.
Okay, so I will respond to this question really with the intense interaction that I had several years ago doing my clinical research on gingivitis, and it was geriatric patients who were really challenged and they were not brushing. And the pictures that I shared about this research showed how heavy the dental plaque was. And if they are not gonna clean, you can wipe it off before you apply the SDF so that it can penetrate deeply and effectively into everywhere and into their mouth and the teeth. So I would say that later on, the dental plaque did not form as much. And this was the thing that we captured and we were very excited about. So to start with, we can definitely use 2x2 gauze and wipe off the dental plaque to allow the penetration of the SDF. Yeah.
Okay, great, thanks. Another question came in was if you need to apply silver diamine fluoride and do an extraction on the same visit, which should be done first? Does that matter?
Well, that's an interesting question. I would, it's just a clinical experience, or, you know, to answer this, I would go first by applying the SDF. Of course, the extraction and all the bleeding afterwards, and putting a gauze and suction and stuff like that. We don't want to get into this mess and do something else. So it has to be, of course, SDF first and then the extraction.
Okay, great. And we're going to wrap it up here with one final question that you sparked some interest in the clinical trial you were discussing on silver diamine fluoride applications for radiation patients, and people were wondering how they can follow the clinical trial if possible.
The trial is registered at clinicaltrials.gov, and we are still in the phase of recruiting patients and concluding what we have, and I'm hoping to have results, exciting results by the conclusion of the trial and statistical analysis. But yeah, it's going very well. It's going to be either clinicaltrials.gov to have the results, or if we are very lucky to get the results published in a timely manner. Yeah.
Great. Well, thank you so much for a wonderful presentation this evening and for sharing your expertise on silver diamine fluoride with our attendees. And thank you to our attendees all for joining and spending your Tuesday evening with us. To our guests, your CE certificate will be emailed automatically within an hour or two, so make sure you check your spam folder if you don't see it right away. And then also be sure to follow us on Facebook and Instagram for links to new free CE events. The link that you can see on the screen will give you access to our archived webinars, including this evening's webinar, which should be accessible in just a few short weeks. So feel free to share this link with your staff and colleagues. And finally, on our Elevate Oral Care website, you will find buttons to request an informative CE eligible staff meeting for your office. Education on the latest evidence in oral health prevention is what we do, and we would be honored to meet with you and your team to help you best serve your patients. So thank you, have a wonderful rest of your week, and we hope to see you all on the next Elevating Care webinar. Thank you.
Thank you.